All right, here we are back again. Wonderful Monday morning here at Space Coast. Today we're doing the second half of the lower extremity kinesiology chapter, chapter 21 in our salvo text. So um, we're still in the lower extremity, but last time, Friday, we had a couple of videos. It was lower extremity upper half. So it was muscles that move the hip, muscles that move the knee. We had the hamstrings, quadriceps, the adductors, the gluteal muscles. We talked about those in detail. Some other muscles thrown in there, tensor fasciae latae, one of my favorites of just saying it. Small muscle that helps form the iliotibial band along with the gluteus maximus. And we discussed a couple of conditions with those muscles. We talked about tightness in the iliotibial band. Oftentimes that's called iliotibial band syndrome. So if we just work the iliotibial band, we might miss out on the cause of the syndrome if we don't go to the muscles that help form that iliotibial band. So we talked a little bit about that. We talked about Osgood-Schlatter disease, tight quadriceps muscles in are usually young athletes. They could also be considered growing pains. So we talked about some of these conditions that in all of these, massage therapists have an important role to play because we can help resolve these, help the body rebalance, facilitate the healing process, and a lot of different syndromes and pathologies, even sciatica. We talk about the piriformis muscle and sciatica. And like I said, when we get back, which hopefully will be soon, we'll address how to access the piriformis muscle specifically. I was talking about the olecranon process, using our olecranon process as a tool. And we do that. We'll do that when we do some deep work. Getting to the piriformis is deep work. So just accessing it, you've got to work deeply because you have to get through that big old thick gluteus maximus muscle. So we talked about various conditions that massage therapy is totally applicable for. Piriformis syndrome, sciatica, Osgood-Schlatter's disease, just a bunch of things. We also talk about how the hamstrings can contribute to low back pain. The iliopsoas, psoas major, can contribute to low back pain. So we discuss that, and the reason we discuss that is because a lot of your clients are going to be coming into you and going, I've got low back pain. Can you help me? So we're going to be discussing how to help with those conditions very specifically. There's specific muscles that we'll address when somebody comes in and says they have low back pain. We'll be talking about this throughout. So, and once we get back into class, then we'll actually be doing some accessing the muscles, showing how to work on those muscles. So today, the second part of the lower extremity, we're talking about muscles that move the ankle. We still have some muscles that have an effect on the knee. Muscle move the ankle, the foot, the toes, the digits. So we'll be discussing those in some amount of detail. In our salvo book, this starts on page 507. In our musculoskeletal anatomy book, it really starts on page 104. So we're going to go right to those muscles. All right, the first muscle they have in both books, 104 and musculoskeletal anatomy book, and it's important to look at some of the information in the musculoskeletal anatomy book because it's specifically for this muscle, it talks about some things that is not in the salvo book, and it addresses some very specifics. So tibialis anterior, it can also be called anterior tibialis. Either way, it doesn't matter. Some texts have it one way. Some texts have it the other way. Doesn't matter. Tibialis anterior, anterior tibialis. Anterior, it's going to be on the front of the leg next to the tibia. It's on the lateral side of the tibia. Does an interesting move when it gets down to the ankle. It crosses over and tucks under the medial aspect of the foot and creates like half of a stirrup. We'll get to the other half. But it creates half of a stirrup. And what it does, because it comes under the foot, it raises the toe in what's called dorsiflexion, movement towards the dorsum of the foot. So it lifts the toe. It's an important muscle in that action of dorsiflexion, lifting the toe, because we need to do that every stride we take. We need to lift the toe so we don't stumble over our own feet, so we don't catch our toes. We need to be able to lift the toe in dorsiflexion, lift the toes in dorsiflexion. So this is a very important muscle. We take a look at the origin, proximal half of the tibial shaft, so close to the knee, proximal half of the tibial shaft, and the interosseous membrane. Remember, that's by definition, interosseous, between the bones, between the tibia and the fibula, the membrane that keeps those bones in close proximity to one another, and it stabilizes the bones in their place. So it's really, it originates close to the knee, but then all the way down the shaft, about the proximal half of the shaft, it's attached to the tibia and the interosseous membrane there. And like I said, its action is lifting the toes. It does a little bit more than that. If we take a look at in either of the book, it also inverts the foot. Inversion is pointing your plantar surface towards the midline of your body. So in some ways, this could be like supination. We'll get to that because your running shoe companies will talk about supination, over-supinating, over-pronating feet. But inversion is pointing the plantar surface towards the medial aspect of the body. So I can invert fairly easily. We talked about eversion, that's lifting the outside edge of your foot, so pointing the plantar surface away from the body, away from the midline of the body. That's eversion. We'll get to the evers. We cannot evert as much as we can invert. We can invert almost to 90 degrees. That's a normal range of motion, almost to 90 degrees. Eversion maybe 15 degrees. That would be normal. Without moving my knee, I can't evert very easily. So if my knee's stabilized and I go to evert, I may have 5 degrees of eversion. That's about it for me. So we'll talk about there. We have some specific muscles for eversion, specific muscles for inversion. So the tibialis anterior, the first muscle, this is on page 509 in our Salvo book, or page 104 in our musculoskeletal anatomy book. Important muscle, because it's dominant. It's the dominant muscle in raising the toes, dorsiflexion. Okay, that's what it does. If our nerve that activates this tibialis anterior muscle, and that's the deep fibular nerve. Sciatic nerve branches into the tibial nerve and the fibular nerve. So it's still part of the sciatic nerve, but it's further down the leg, so it gets a different name as it branches, as it forks. So this fibular nerve, as the deep fibular nerve activates this. If we pinch that nerve, if we sever that nerve, if we somehow it's inactive, we can have a condition called drop foot. Drop foot means I can't dorsiflex. I can't lift the toe. So how I would walk, I'd have to lift my whole leg to do that, and my foot would just drop. So that's called a condition called drop foot. It says in the musculoskeletal anatomy book, paralysis of this muscle causes drop foot. Okay, so that's a condition. You'll see people, every once in a while you see people, maybe who've had strokes or who have other conditions, they walk kind of funny. They have to lift their whole leg to move the feet. Typically we don't have to do that. We just lift the toe, we stride. And that's not what happens if this muscle is deactivated, the tibialis anterior. The other issue with tibialis anterior, it's usually the muscle where if people have shin splints, another condition, muscular condition, and that's typically an overuse syndrome. And shin splints can be extremely painful. Ask anybody who's been in the military. At some point in time, they probably had shin splints because they've got you either running in boots or doing something that, in sand, going from a hard surface to a soft surface can typically guarantee you're going to have shin splints. If I run downhill, that guarantees I'm going to have shin splints if I don't do it on a regular basis. because of overstretching of the tibialis anterior, because your foot is overstretched as you run downhill. So there's certain things you can do that can create shin splints. If I haven't walked on the nice soft sand beach of Brevard County in a while, I go out there and I walk a long way in soft sand. I have to dig in a lot with my foot to push off, to stride. I'm going to create shin splints because overuse of that tibialis anterior. I have to pull my toes up to take the next stride. So tibialis anterior can be a problem. It can be a problem for a couple of reasons. Shin splints is something we can easily have an effect on. We can do some stripping along that lateral tibial bone. We can do some cross fiber friction along there. And oftentimes people don't know they have shin splints until you touch the muscle. And they go, I didn't know that was there. What is that? And, a knowledgeable massage therapist would go, oh, you've got some shin splints. Did you change surfaces you walked on? You walked on the beach, recently. You run downhill or walk downhill recently. And here, the only places you can walk downhill is really the causeway. So have you been, started walking the causeway, started running the causeway? If you haven't done it in a while, it will create shin splints. And like I said, it's a condition we can help. It's a tendinitis type condition. And I've said we can help tendinitis. We can have a dramatic effect on lots of different tendinitises. This is a tendinitis type condition. Right, so that's our tibialis anterior. It goes from the origin is on the tibia or on the interosseous membrane. It inserts on the first metatarsal. That's the foot bone on the big toe side. So it goes from the outside of the lower leg and it crosses over to the medial aspect of the foot, and it inserts on that metatarsal one. And medial cuneiform is one of our tarsal bones. It's on the medial aspect of the foot in the ankle area. So it creates like a stirrup the way it crosses over the foot and inserts on the inside of the foot. Okay, that's our tibialis anterior. Important muscle. We'll get to that as we get back together and start doing massage. It's an easy one for us to access, easy one for us to manipulate. Like I said, if people have shin splints, wow, we can do a lot with that. So it's one we need to be knowledgeable about. Extensor digitorum longus and brevis. By the name, remember when we were talking about extensors of the wrist and fingers, they were all named extensor. So same thing with the ankle and the digits of the foot. If we have an extensor digitorum longus, what does it do? It extends the toes. I'm not going to be asking about the origin and insertion of the extensors. We know it's somewhere on the lower leg, extensor digitorum longus, the fibular head, the head of the fibula, our more lateral lower leg bone. Proximal 2/3 of the anterior shaft of the anterior fibular shaft, lateral condyle of the tibia. So a lot of origins. I'm not going to ask specifics about the origins of the extensors. What I'm typically going to ask is, what muscle extends digits 2 through 5? Extensor digitorum. Longus or brevis, the longest is the longer one, brevis is the shorter one. Okay, so we have a pretty good idea. They're going to insert on the digits, the phalanges of the foot. We know that because they have an effect on the phalanges of the foot. They extend them. So extensor digitorum longus and brevis. On the extensor, on those we know they extend the digits, not the big toe, because we have a specific muscle that extends the big toe, and that's the extensor hallucis longus. Remember, the hallux is the great toe. Pollux is the thumb. Hallux is the great toe. So anything extensor or flexor hallucis is going to have an effect just on that large toe. It's called the great toe in anatomy books. So it's just going to have an effect on the great toe, anything hallucis. So extensor hallucis. we have longus. It's a extensor of the big toe. All right, and that's on page 510 in our big book, in our salvo book, and it inserts on the distal digit or phalanx of the great toe. That's why it has such an effect on the great toe, as it extends the great toe. All right, so we've got that. If we have a muscle that's called an extensor, it extends. If we have a muscle called a flexor, it's going to be flexing. Just like the ones that we talked about with forearm, flexion and extension of the wrist and fingers, we have that same setup in the ankle and toes area. Okay, so we've got that. And like I said, I'm not going to ask about origins, insertions. If it extends the toes, it's got to insert on the toes somewhere. So we know that. I'm not going to ask about the origins. There are multiple origins all over the lower limb. Okay, we're good. All right, we've got 3. Here's our everters. And they're called fibularis, and we have fibularis longus, fibularis brevis, and fibularis tertius. Tertius means the third. So we've got fibularis longus, brevis, and tertius. Fibularis, so they originate on the fibula, so they're called fibularis, but they have another name. The other name is peroneus. Peroneus, longus, brevis, and tertius. So anything fibularis is also peroneus. 25 years ago, there was no fibularis. It was all peroneus. Everybody learned peroneus. Now it's either or. Typically, the texts have it as fibularis. That gives you a better idea of where it is. Obviously, it attaches to the fibula. And then it goes down to the foot. And in the 3 of them, the fibularis longus inserts on the first metatarsal, like the tibialis anterior did. The medial cuneiform, like the tibialis anterior did. And it everts the foot. Remember I said it's tough. We don't have a big range of motion in eversion. That's lifting up the outside of the foot. All 3 fibularis muscles evert the foot. They don't move a whole lot. And they can be problems when we're working on somebody. They're all on this lateral side of the lower limb. They can be extremely tight, especially in runners, athletes, can be extremely tight. So oftentimes we want to go in there and we want to manipulate the tissue, but I'm still not going to gain a whole lot of mobility because our foot just doesn't mobilize that much on eversion. Some people can walk on the inside of their feet. Usually their knees are bowed in, but we really don't have that much flexibility on eversion, even though we have the 3 everters. Fibularis longus or peroneus longus, fibularis brevis or peroneus brevis, and fibularis tertius or peroneus tertius. So those 3 are everters. Don't really care about the origin insertion. Again, it hasn't been on the imblex of the peroneal muscles. This is the peroneal region, the lateral aspect of the lower limb, lateral aspect below the knee. That's the peroneal region. So on the outside of the leg, we've got the peroneal region, we've got the peroneal muscles, but now they're called the fibularis muscles. So typically when I put them on a test, I'll say fibularis and put peroneal in parentheses. They don't necessarily do that on the imblex, and there have been questions about those muscles, and it's typically what's the action of the peroneal muscles or where are the peroneal muscles located. Like I said, they may say fibularis, but they may say peroneal. Either way, you need to know that. All right, we don't have a whole lot of notes, except it says that fibularis are the peroneal muscles. Okay, that's an important distinction. You need to understand that these peroneal muscles are the fibularis muscles. They're one and the same. Don't worry about, like I said, origins and insertions. All right, we've got some really, really important muscles. These are muscles. I will talk about how to really work the calf muscles because they are, in the massage world, they're underworked. I'll put it that way. they can cause all sorts of problems. We've got two huge calf muscles. They're large, they extremely powerful, they're muscular. We can do a lot with them because we've got the two bones, but here at the calf muscle, the sural region, we've got these two large muscles that we can do a lot of manipulation with. We can stretch them, we can really dig into them, they can take a lot, they can withstand a lot of pressure. One is superficial, that's the gastrocnemius. The other is deep to the gastrocnemius. That's called the soleus. It looks the shape of a fish, like a sole fish. So it's flat, but it's the more powerful of the two calf muscles. And what do they do? What they do together, they both attach to the calcaneus, our heel bone, by the calcaneal or Achilles tendon, which is the largest, strongest tendon in the body. So we've got these two muscles that come together. We have a lot of muscles that come together and have a similar insertion. They both insert, like I said, on the calcaneus, the heel bone, by that calcaneal or Achilles tendon. And extremely powerful. What do? They lift us up on our toes. So this is plantar flexion. We had dorsiflexion where we lifted the toes. Plantar flexion is pushing down with our toes. Gastrocnemius is sometimes called the toe dancer's muscle. In ballet, it's incredibly important to get up on your toes. So we've got these two muscles, incredibly powerful. The soleus is the stronger of the two. It's fatigue resistant. So these are what we push off with our feet. Remember, the psoas major initiates walking. It flexes the hip. We've got the gluteal muscle that extends the hip to push off, but we also have to push off with our feet and our ankles. So that's the gastrocnemius and soleus. We can walk. Humans were made for walking. We can typically walk all day. Some people do. Okay, some people are on their feet a lot. Anybody who's on their feet a lot, anybody who walks a lot, anybody who gets up on their toes a lot, they're going to have extremely strong calf muscles, gastrocnemius and soleus. These two are utilized all the time. So as we utilize them all the time, they can also create some problems. Very often we have trigger points within the musculature of the gastrocnemius and soleus, and oftentimes it's the soleus. Now the gastrocnemius is easy to access. It's superficial, large. It's got two heads to it, two bellies. Gastroc means belly. Two bellies to it. So it's got a medial and lateral belly to it, or they have it in the musculoskeletal anatomy book as medial and lateral head. So it's got two parts to it. We can actually do some nice work in separating those and getting that gastrocnemius nice and flexible. We can do some stretching because easy to stretch those muscles. And I'll show you a couple of methods. It almost looks like you're breaking ankles because we have great flexibility with those muscles. You can create a lot of motion with them. So it looks like it might be too much, but it isn't. We can take it. We're constantly stretching those muscles or utilizing those muscles, and they have to move our entire weight as we push off. So they can take a lot of pressure. They can take a lot of stretch. Don't worry about it. We'll talk about this more. Soleus is deep. Soleus is deep to the gastrocnemius. Gastrocnemius originates on the femur. So it does have a slight effect on the knee. It has a little bit, it can flex the knee, but not while it's doing plantar flexion. Can't do both at the same time. So either does one or the other. So, but if we're just flexing the knee, it can assist. It can be a synergist to our really strong hamstrings muscles and flexion of the knee. So it originates on the femur. The soleus originates below the knee, so it only crosses one joint. Gastrocnemius is biarticular, soleus uniarticular. So soleus a little bit more fatigue resistant and stronger than the gastrocnemius. and more difficult to access because the gastrocnemius is more superficial. It lies right on top. We can easily access that gastrocnemius. Soleus, we kind of have to get to the sides of it. Unless we work really deeply into the gastrocnemius, it's tough to get to the soleus because it's, for the most part, covered up by that gastrocnemius. But we can get to it. We can also stretch individually the gastrocnemius and individually the soleus. Depends on whether our client is straight-legged. Then if we're stretching as we're dorsiflexing, we're stretching the gastrocnemius. If the client is flex knee and we're dorsiflexing, we're stretching the soleus because we've deactivated the gastrocnemius because it crosses two joints, crosses that knee joint. So we're going to talk about the differences in stretching gastrocnemius and soleus. We can stretch each muscle individually. Okay, so when we do some range of motion type movements, I will stretch the gastrocnemius and I'll stretch the soleus individually. But it's harder to access that soleus, and oftentimes it is the problem. It's a problem area. So people who have Achilles tendonitis can be from overuse. Well, the gastrocnemius and the soleus form that Achilles tendon, and if they have any inflammation of the Achilles tendon, it could be the gastrocnemius or the soleus causing the problem. We've got a third muscle in there that we'll talk about in just a minute that also attaches to the calcaneus by that calcaneal tendon. But really those two big calf muscles, gastrocnemius and soleus, are the ones that help form that Achilles tendon. Remember, biggest, strongest tendon in the body, and it's big and strong because we utilize it all the time because we're constantly walking, we're constantly getting up on our toes, constantly moving, standing. We have to activate those muscles. So they're constantly being activated. That's why they're big, they're strong, and why we need to pay attention to them. We can get into them, we can warm them up, we can mobilize them, we can stretch them. So there's a lot of things we can do with the gastrocnemius and soleus. I can do, because of how big they are, I can do effleurage, petrissage, I can do tapotement on them, I can do friction on them. So there's a lot of things we can do. They're big, strong muscles. They're meant to be big, strong muscles. So easy to access, soleus a little bit more difficult, gastrocnemius extremely easy to access. All right, so they're fun to work on, in my opinion. These are some of the more fun muscles to work on because people don't know how tight they are, and we get into them, we loosen them up, and they get up and they go, wow, I feel like I can walk better. I feel, like I can go and run. I can do anyway. Once we work on them, loosen them up, get them nice and flexible for our clients, there's a world of difference. They will talk about they walk better, lots of stuff. Okay, so these are important to us. There's another term that we're going to throw out at you. We talked about the pes anserinus in the last class, whereas the conjoined tendons of the sartorius gracilis and the semitendinosus. So that's a term. The two big muscles of the calf, the gastrocnemius and the soleus, form what's called the triceps surae. Triceps, three heads. Remember, the gastrocnemius has two. Soleus is big, flat muscle. But they form the triceps surae, three-headed sural muscle. So those are in their own compartment. If you took a look at the video on runner's compartment syndrome, from what I allowed to go out, I think on Wednesday or Friday, then you'll know what I'm talking about compartments. The lower leg has an anterior compartment, has a lateral compartment, a posterior compartment, has multiple compartments. And that's where we have a fascial coating around muscles or muscle groups. So the two muscles, the gastrocnemius and soleus, forms posterior compartment, and together they're called the triceps surae. Triceps surae is mentioned on page 111 in the musculoskeletal anatomy book under the soleus muscle. It just says triceps surae. Together, gastrocnemius and soleus are referred to as the triceps surae and are powerful plantar flexors of the ankle for raising the heel and running and jumping. Powerful muscles, together they form a term called the triceps surae. This has been on the imblex. Pes anserinus has been on the imblex. Knowing where they are and what muscles create them is important to us as far as the imblex. All right, so talk about gastrocnemius and soleus. The third muscle that attaches by that calcaneal tendon to the calcaneus is called the plantaris. Interesting muscle in that it's small and weak. It's in there with two really huge muscles that are big and strong, fatigue resistant, allow for incredible strength as far as raising up on your toes, propelling you in walking, running, all this jumping. Okay, and we've got this little itty bitty muscle. It's relatively short. It originates on the lateral epicondyle of the femur and attaches to the calcaneus by that calcaneal tendon. So it's biarticular, like the gastrocnemius, but it's so small. But it's got a huge tendon, extremely long tendon. And in our musculoskeletal anatomy book, let's see, plantaris, it says, it's absent in some people. It's not there with some people. Some people just don't have it. Why is that? Genetics. Genetics plays a part, but also we really don't need it. It's small. I've got these other two powerful muscles, gastrocnemius and soleus, that I use for my plantar flexion. This plantaris, I don't really need it. It's not necessary. So some people don't even have it. But if you need to have a tendon surgery, you need a tendon replaced, sometimes they will take the plantaris tendon for tendons of flexion extension of the arm to replace torn tendons, injured tendons. And it says that under the plantaris in our salvo book, it says long tendon of the plantaris sometimes used for reconstructive surgery. So even if I do have it, it's a part that can be used for other things. So reconstructive surgery. So it's not really a powerful muscle. It's not an important muscle to us because to massage it, where is it located? Behind the knee. We remember that's an endangerment site because the nerves and the blood vessels in that area. We don't push deeply into the back of the knee. Nothing good to massage there. We can go lightly over it, but plantaris is not an area that we're going to focus on. Gastrocnemius and soleus, absolutely. Plantaris, nah. So it's not one that I'm going to ask a whole lot of questions on. It does join with the gastrocnemius and soleus to form that Achilles tendon or calcaneal tendon, but it's not really that important for us as massage therapists. All right. We do have a tibialis posterior, and that tibialis posterior, it also, along with the tibialis anterior, does some inversion of the foot. And I'm not going to ask any questions about tibialis posterior. It hasn't been on the imblex. Not really going to ask any questions. It's deep it's so deep it's on the posterior side of the tibia, and hard to access because we've got that gastrocnemius and soleus in the way. So hard to access. We don't really do a whole lot of massage here. It also can be involved in the shin splint thing that the tibialis anterior is involved with, but we can't really access it. If we look at palpation for the tibialis posterior, it says tendon is palpate just posterior to the medial malleolus. Back in our skeletal system, our medial malleolus is sometimes what we call the ankle bone. Let's see if we can see that. It's the bump on the inside of the ankle. Our lateral malleolus is on the outside. That's the bump on the outside. Sometimes, like I said, called the ankle bones. So our medial and lateral malleoli is plural of malleolus. The they're muscle attachment sites. Um, so, um, and they also hurt when you whack them. Just saying, we don't have a whole lot of padding there. It's bone, it's skin. So if you hit that inadvertently, it really doesn't feel good. I'm usually just whacking bone when I do that. And I've obviously done it because I know how much it hurts. Okay, so tibialis posterior, origin, posterior tibial shaft, posterior. So it's deep to the gastrocnemius and soleus, hard for us to access. Like I said, the palpation in musculoskeletal anatomy book says the tendon is palpated just posterior to the medial malleolus as it passes around towards the insertions on the plantar surface of medial side of foot during active inversion of the foot. Muscle belly is deep to the gastrocnemius and soleus and can't be palpated. So too deep. We don't do a whole lot with tibialis posterior. It does help with inversion of the foot. It assists the tibialis tibialis anterior with inversion of the foot, and it does a little bit of plantar flexion. So it's a synergist to the gastrocnemius and soleus. And plantar flexion, your tibialis anterior dorsiflexes, raises the toes. It does a little bit of pushing the toes down, but it's a synergist. It's a relatively weak muscle as far as plantar flexion. So I'm not going to ask any questions about it. Relatively small, hard for us to palpate. Can only palpate the tendon. So not really a big thing for massage therapists. We won't have any questions on it on the index. All right, then we have in our big book, after tibialis posterior, we have flexor digitorum longus and flexor hallucis longus. Flexor digitorum, flexion, going to be curling our toes under. Flexor digitorum longus. Remember, it's going to insert on digits 2 through 5, not on the great toe, but digits 2 through 5. And what does it do? It's a flexor, so it flexes the toes. So if we look, action flexes digits 2 through 5 at it goes all the way out to the end of the toes, so at the distal interphalangeal joints, the proximal interphalangeal joints, and the metatarsal phalangeal joints. So the knuckles of the toes, the dips and pips. We've talked about those already. All right. So, and it does a little bit of plantar flexion and inversion, but remember, it's a synergist. What its action is as a flexor is to flex those toes. And then we have the flexor hallucis longus. Okay, that flexor hallucis longus, what does it do? Hallux is the big toe, so it flexes the big toe. If you don't want to go any further than that, origin insertion, I'm not really concerned about. It's just going to be, it's going to insert on that big toe, and it flexes the big toe. In our musculoskeletal anatomy book, they talk about another small muscle. They group it with the plantaris, but they talk about the popliteus. Remember, the back of the knee, that's our popliteal space, that's our popliteal region. We've got a small, very small muscle called the popliteus back there. Once again, we don't really massage it. It's not in our playbook as far as massaging the back of the knee. It's not part of our routine. If we brush over it, fine. But we don't work deep into the knee. Nothing there to really have an effect on. But there are muscles there. We already talked about the plantaris, but it plays such a minor part, and some people don't even have it. The popliteus, once again, it says it's the deepest muscle at the posterior knee joint. What it does, it unlocks the knee when we go to do flexion of the knee. In our musculoskeletal anatomy book, it says it's the key that unlocks the knee. It reverses the origin and insertion, laterally rotating the femur on the tibia or medially rotating the tibia on the femur, depending on which is fixed. All right, so what it does, the key that unlocks the knee, it helps with if we're in a flex position, it can assist in rotation of the tibia. Remember, we're talking about the knee joint. Knee joint is a hinge joint. But when it is not fixed, as in we have an extended leg, it doesn't rotate when our leg is extended. But when our knee is flexed, it can rotate, but not a whole lot. There's a small, weak muscle. It unlocks the knee to allow for just maybe 10 degrees of rotation. Very, very little rotation. So if we're not standing, if we're not putting any pressure on the leg, we can actually rotate at the knee, rotate the tibia or the femur, depending on which one we're utilizing to do a little bit of rotation, but it's very minor. We certainly don't want that when we're planting or pushing off because we want stability of the knee. This creates an instability of the knee. So our popliteus, small muscle at the back of the knee, really doesn't have an effect on us because, again, we don't massage the back of the knee. We don't do anything deeply at the back of the knee. This is a small, weak muscle, has a very specific job. It's not even in our salvo book. They don't even discuss it. So I just wanted to bring it up. It's not something that we're going to be doing a whole lot with. All right, and that finishes our lesson 9, the muscle of the ankle and foot movements. That was it. We're not going to have a second part to this today. Wednesday, we start into the muscles of the head, neck, and trunk. These are really important to us. Today, some of the muscles we talk about are very important. We need to know about tibialis anterior because of shin splints, because of some of the things it does, drop foot, gastrocnemius and soleus, certainly. That's a big part of what we work on when we're talking about a lower leg. I can spend a lot of time on the gastrocnemius and soleus, and a lot of my clients really, really appreciate it. And it's because they can be extremely tight. They can affect your back. Once again, we're talking about, we talk about hamstrings having an effect on low back. When people come in and talk about low back pain, there's certain areas we need to address. The low back, obviously. The erector, we'll talk about the erector spinae in our second head, neck, and trunk set of videos. That has an effect on the low back also. But we have to address, and sometimes we have to educate our clients when they come in and say they have a low back issue. Yes, we want to work the low back. Absolutely. We want to work along the back. We'll talk about the specific muscles when we talk about head, neck, and trunk in the next couple of videos. But we also want to work the hamstrings, and sometimes we have to educate our clients why we're working the hamstrings. And oftentimes I'll also say, by the way, the calves can have an effect on the low back also, just in the way you walk. So we'll discuss that, and we'll talk more in depth about when somebody comes in, we do an assessment, they talk about low back issues. We have to sometimes educate them, tell them why we're working on the muscles we're working on. But that's what we do. We're going to be talking about assessment, working those muscles. All right, the next two classes will finish out our kinesiology chapter 21. And these are going to be the muscles of the head, some facial muscles, head, neck, a lot of neck muscles that are extremely important to us, a lot of conditions caused by tightness in the neck muscles or hypertonicity in the neck muscles. Headaches, a thing called torticollis. We'll get to all these, and we'll talk about how to address these, what muscles may cause these. And then we're going to be talking about the trunk muscles. That'll be the second of the days, So Wednesday we'll be talking about facial muscles, neck muscles. Then Friday, and we're both starting at 9:30-ish. Friday we'll talk about the trunk muscles, and that finishes our chapter. We'll talk about some of the nerve activations. We'll do a little bit of review. on Friday, and then you're going to have the today I will go ahead and activate the quiz for the lower extremity. Friday I'll activate the quiz for the head, neck, and trunk muscles. So you can look forward to a couple of quizzes coming your way. Today, like I said, we'll activate the lower extremity quiz. 33 questions, simple, includes a lot of the stuff I've talked about, a lot of the stuff that I told you about. This is going to be on your quiz. So should be relatively easy for you. Don't forget the musculoskeletal anatomy book is a very, very good resource along with our salvo text. So don't forget that. The musculoskeletal anatomy book has some notes in it that are important notes that have some things like shin splints for the tibialis anterior that our salvo book doesn't mention. Okay, so that's it for today. Like I said, we will come back on Wednesday for live class on Wednesday morning. Start talking about some of those really important neck muscles. See you then.